Assalamu alaikum. Welcome back to Ruxana Foundation's YouTube channel. Today we'll be continuing our topics from GI anatomy. We'll be discussing about hernias and some key highlights from physiology of GI tract. Hernia. Hernia is basically popping out of organs from the body, from the abdominal wall, if I'm being specific here, where we're going to talk about hernias associated with abdominal wall. So in definition, this is just a protrusion of peritoneum along with the organs surrounding the abdominal cavity through an opening, and it mostly happens at a site of weakness. There are certain anomalies that might be associated with hernias that require immediate attention and immediate intervention. The first one of them is incarceration, and the second one is strangulation. Incarceration is when a hernia comes out of a body organ through the abdominal wall and it does not reduce back to its original location. In strangulation, there is definitely irreducible hernia, but with it, there's going to be a compromise of ischemia. There's going to be a compromise of blood supply that will lead to ischemia and necrosis. When incarceration or strangulation happens, it's very emergent to deal with that condition, because if that is not dealt with on emergent basis, then there might be gangrenous necrosis of intestine. The first hernia that we're going to talk about is Spigelian hernia. To understand this, I need you to first engrave in your minds the concept of semilunar line. As you can see here, that this is the semilunar line that is bounded medially by the rectus abdominis muscle and laterally by the oblique muscles. And there's this wide gap that you can appreciate. This is actually the space through which Spigelian hernia comes out of the abdominal wall. There is going to be a fascia that will cover this white highlighted area, which is known as the Spigelian fascia. Now, the other key concept here is about the arcuate line. Arcuate line, it's an imaginary line that is present midway between umbilicus and pubic tubercle, or pubic symphysis. And below this line, the posterior rectus sheath, it is deficient. What I mean by that is normally there are two components of rectus sheath. The first one is anterior and the second one is posterior, being formed by various muscles, the oblique muscles that line the lateral, anterior, and somewhat medial wall. Not the medial wall, just the lateral and anterior wall. Below the arcuate line, all these fascias from these oblique muscles, they come anterior to the rectus abdominis muscle, and posteriorly there's no fascia that will line the rectus abdominis muscle. Above the arcuate lines, there is a proper anterior rectus sheath and posterior rectus sheath. But below arcuate line, there's just anterior rectus sheath. This is not high yield for your USMLE Step 1, but it's very important to understand the concepts of hernia. So about Spigelian hernia, it's going to come out through this white highlighted area here where I'm pointing the cursor at, and it most often happens below this arcuate line because of the fact that this posterior rectus sheath, it's deficient posteriorly below the arcuate line. Spigelian hernia is also known as spontaneous lateral ventral hernia. Well, that's because it can happen spontaneously because there is some deficient part in terms of posterior rectus sheath and that white highlighted area that I showed you guys. Its presentation is going to be typical as is for other hernias, but this is going to be present, this palpable mass is going to be present somewhere around the lateral wall of rectus abdominis and the medial wall of oblique muscles. So be vigilant for that. Moving on, our next topic is diaphragmatic hernia. As the name indicates, that this is popping out of organs through an opening in the diaphragm. Normally, during embryologically, there's pleuroperitoneal membrane that's going to develop into diaphragm, And then there's pharyngoesophageal membrane that is surrounding the esophagus area, but that is not involved in the formation of diaphragm. Because pleuroperitoneal membrane abnormality or pathology happens during the development of an embryo or fetus, it is this anatomical defect is most likely going to be present in babies, in infants. In this image, you guys can appreciate this pleuroperitoneal membrane that is not going to be well developed in cases of diaphragmatic hernias in infants. So that hernia is going to come out here. The organs that are going to be coming out of this opening are mostly the small intestine parts. So when that happens, since above this pleuroperitoneal membrane are the lungs, and this mostly hernia happens on the left side, so the left lung is likely going to be with reduced breath sounds in a scenario that will pop up on your USMLE Step 1. And when that happens, we'll be able to hear bowel sounds in the left hemithorax. Quite typical bowel sounds would be heard as we can auscultate in any normal physical examination of abdomen. This is also true that why there is this hernia popping out from the left side of the diaphragm is because the right hemidiaphragm is quite protected by the liver. In adults, the pharyngoesophageal membrane, it's going to be deficient and going to allow the stomach pop out from that membranous opening. In this image, this is not a high quality image, but you guys can truly appreciate. This is the diaphragm, this is the esophagus. So the pharyngoesophageal membrane is going to be somewhere around here, and the stomach is going to pop out from this opening, which is deficient because of the weakness of pharyngoesophageal membrane. In terms of diaphragmatic hernias in adults, there are two types. Both fall under the hiatal hernias because this is the hiatus through which the organs are going to herniate. The first one is sliding hiatal hernia. Sliding means simple sliding of gastric cardia through this opening. And since this herniated part is also make the lower esophageal sphincter incompetent, patient is going to be presenting with symptoms of heartburn and GERD. There's going to be an hourglass stomach appearance on an X-ray, on a chest X-ray that we will be able to appreciate, and this is the most common type of hiatal hernia. The second is paraesophageal hiatal hernia. As the name indicates, this is going to be a herniation around the esophagus, and when that happens, the lower esophageal sphincter is not going to get compromised, and patient is not going to be likely presenting with GERD symptoms, heartburn symptoms. The next one is indirect inguinal hernia. It is very important to differentiate indirect inguinal hernia from direct inguinal hernia. Direct, when that words come up, you're going to think about directly coming out of the abdominal wall. Indirect inguinal hernia, it does not come out directly from the abdominal wall. In fact, it makes its way from inner ring, the internal inguinal ring, to the external inguinal ring. So it's going to follow a proper path coming out of the abdominal wall. As far as the indirect inguinal hernia is concerned, the herniation is going to be lateral to the inferior epigastric vessels. This is very high yield for USMLE Step 1. And in our last topic that we discussed in our last lecture, I clearly highlighted the concepts associated with inferior epigastric vessels and the Hasselbalch triangle. So it's very important to keep that triangle in mind. Sometimes in cases of infants, there is processus vaginalis that might not get obliterated completely and will allow the organs to herniate from internal inguinal ring to external inguinal ring and directly into the scrotal area, into the scrotum sac. This is also very important to know that in indirect inguinal hernia, because it's going to make its way through the inguinal canal which is covered by 3 layers of spermatic fascia. The hernia is going to be covered with these layers as well. Next is direct inguinal hernia, and it's going to protrude directly from the abdominal wall. And in abdominal wall, the specific region for it is the Hasselbalch triangle. This is going to be medial to the inferior epigastric vessels but lateral to the rectus abdominis muscles. Why this is important is because these are the key landmarks that a surgeon might take to approach a particular hernia for its repair. Hernias, the inguinal hernias, they most often happen in male and mostly in old age because of the weakness of the abdominal wall muscles and fascia, but they can also form when there is a trauma to the abdominal wall. Maybe a patient might appear in your question that he had or she had a history of some abdominal surgery. This will indicate towards pointing out inguinal hernia in your answer. Okay, the last high yield hernia is femoral hernia. Some key points about it, that it happens in female most commonly, and it's more likely to get incarcerated and strangulated. So when that question about this is going to appear in your exam, you're going to think of management as soon as you can, and that is going to be emergent, and that is going to be repair on elective basis and not emergent basis. This is very important to know, and it's going to pop out of the femoral canal. It's not high yield to know the boundaries of it, but just for your understanding, I'm going to explain those here. Anteriorly is the inguinal ligament, posteriorly is the pectinate ligament, and laterally is the femoral vein, and medially it's going to be lacunar ligament. So just differentiate this from other hernias by knowing that it's going to be more likely in female and more likely to get incarcerated. And if that appears in your question, we need to manage it. For inguinal hernias, we can definitely wait and watch if the hernia is not incarcerated or strangulated. But for femoral hernia, we're definitely going to need management as soon as we can on elective basis and not emergent basis. On emergent basis, there's going to be management only for incarcerated or strangulated hernias, which are going to be the inguinal hernias or the Spigelian hernia that we have discussed. This also goes for diaphragmatic hernia, but that isn't that high yield for USMLE Step 1. Just stick to the inguinal hernias and femoral hernia and Spigelian hernia, and you'll be able to solve the questions related to these parts. Thank you so much for watching today's video. Please do like and subscribe to our channel, and do watch our videos and share with your fellows that might be able to ace their USMLE Step 1 exam. Thank you so much.